In this video, we'll be covering one of the more seemingly complicated topics of introductory anatomy, and that's going to be the cavities of the body. When we look at how we divide up these cavities, we're going to have two primary aspects, a posterior aspect and a ventral. The posterior cavity is going to include the cranial cavity, which is going to be anything that houses the brain, so all the bones that make up the skull that make that cranial cavity. And then once we get down past the foramen magnum of the occipital bone, we're going to be into the vertebral canal, which will extend all the way down to the sacrum. Ventrally, we have our thoracic cavity and our abdominopelvic cavity, with the diaphragm being that physical separation between the two. So we see we have our cranial cavity housing the brain, foramen magnum. As soon as we cross that border, now we're into our vertebral canal part of that posterior cavity. We have our diaphragm sitting right across the middle of that ventral cavity, separating the thoracic cavity, anything housed by the ribs and the vertebra posteriorly, and then the abdominal pelvic cavity just below it. Now, when we look at that thoracic cavity, we're going to see it's going to be divided up into three other cavities and a space. We have our bilateral pleural cavities. We have a pericardial cavity associated with the heart. And then we have our mediastinum, which is the space associated around those three cavities. Below the diaphragm, we have our abdominopelvic cavity, with the abdominal cavity being the more superior portion of it, and the pelvic cavity being the more inferior portion. Now, there is no true physical barrier between the abdominal cavity and the pelvic cavity. We just consider it to be roughly across where the top of the iliac crests are. In the ventral cavity, we have a very specialized series of cavities called serous cavities or membranous cavities. Now, each of these are going to have a single function, whether we're talking about the ones in the thoracic cavity or the pelvic cavity. They're there to reduce friction. They're always going to be associated with organs that undergo a certain degree of movement. Now, once we get into each specific organ, these membranous cavities will take on a specific function just for that organ specifically. So when we're looking at these serous cavities, it's important to realize we've got three components: two membranes and the fluid that sits between them. We have a visceral layer membrane that sits directly on the organ in question. Then we get a parietal layer which surrounds it more superficially and adheres itself to the tissue walls around that said organ. And in between, filling up that space, we have a fluid. So it's a fluid-filled cavity. We see we have our pericardial cavity, which we'll get to the specifics of these in just a moment, with our visceral layer sitting directly on the heart and the parietal layer sitting superficial to it, with the serous fluid just in between. We have our bilateral pleural cavities associated with the lungs, and then we have our peritoneal cavity associated with the abdominal pelvic organs. It's important to make the distinction that we don't find these organs within their said cavities. More specifically, the cavity surrounds the organ. So if we look at the analogy of a fist being plunged into this inflated balloon, we could use this analogy to describe the visceral layer of that membrane as the balloon that sits in contact with the fist itself, while the parietal layer is going to be the layer of the balloon that sits more superficially on the outside. So here you wouldn't say that the fist is inside the balloon, but rather that the balloon sits around the fist. Now, all the organs that I'd mentioned earlier that are associated with these cavities undergo a certain degree of movement. So if we took the fist and we moved it about, the fluid in between these two membrane layers is going to provide a lubrication so that we don't get tissue friction. Looking at the pericardial cavity specifically, we get some new terms introduced. We don't just call it a visceral layer and a parietal layer. We call it the visceral pericardium and the parietal pericardium. These are going to be layers of membranous cavities specifically associated with the heart itself. The layers make up the cavity. The space between those layers is only considered the cavity. So the first misconception of these cavities is that they have a high volume. The volume of this cavity is only the space between the two membranes. So they are much smaller volume cavities than their gross size would lead you to believe. We have our visceral pericardium directly on the heart. We have our parietal pericardium surrounding it, and our serous fluid, lubricating fluid, sitting in between those membranes. So now as that heart moves about inside the pericardial cavity, we reduce friction. Now, I had said earlier that each of these cavities also hold a specific function for their particular organ. They all help with lubrication, but in this case, we will get a fibrous layer to this outer parietal pericardium. That's going to give the heart a little bit of mechanical leverage for when it contracts. I mean, optimally, when the heart beats, we're hoping to get 60-65% of the blood ejected from that heart. Once we get down to 40% ejection fraction, now we have the potential for cardiac failure. So we use the serous membranes for lubrication around the heart, but also for mechanical advantage to increase that ejection fraction. And again, I want to make the distinction. If this were the heart, the visceral layer sits right on the heart itself. The parietal pericardium sits outer to it. The serous fluid in between, where the air would be inside this balloon. And the volume of the pericardial cavity is only the volume of air inside that balloon, not including the volume of the heart itself. With the lungs, just like we saw with the pericardial cavity, we introduce new terms again. This time, the pleural cavity. So we have our visceral pleura and our parietal pleura, specific to the lungs, with again the space in between being our pleural cavity. The lungs also move just like the heart. As we inflate and deflate the lungs, we have the potential for friction. That pleural cavity is going to reduce that friction. Specifically for the lungs, however, it's this pleural cavity that allows the lungs to stay inflated. We are going to get a transpulmonary pressure exerted because chambers with fluid don't like to be expanded or contracted in volume. So as we move the diaphragm, as we expand the ribs, it's going to create a pressure inside that pleural cavity, which will allow those mechanical changes to result in expansion and contraction of the lungs. That's why sometimes when you get an open wound here, it allows air into that pleural cavity, the lung will deflate and you get a collapsed lung known as a pneumothorax. Now, we kind of teased earlier, in that thoracic cavity, we had two pleural cavities associated with the lungs laterally. We had a pericardial cavity associated with the heart medially, but then we also had this space. It's called the mediastinum. The mediastinum is not a cavity. It's a region or a space within the thoracic cavity. Specifically, it's going to be anything found between the lungs medially, between the sternum and the vertebra from anterior to posterior, and then from the thoracic inlet, the border made between the clavicles, the sternum, and the first ribs, all the way down to the diaphragm from superior to inferior. Anything within those borders is going to be our mediastinum. So the mediastinum, within it, we find the heart. We find the pericardial cavity. We also find the esophagus, the trachea, the aorta, the large veins, the vena cavas, as they come back to the heart to enter into that right atrium. All of those pieces of anatomy are going to be found within the mediastinum. Now we move inferiorly, past the diaphragm, and now we're into the abdominopelvic cavity. It's going to be divided up into abdominal and a pelvic, no true border physically separating those two cavities. Just like we saw with the other two types of serous membranes, we have specific terms for the abdominopelvic cavity. We have our peritoneum, but similar kind of nomenclature. Visceral peritoneum sits on the organs. Parietal peritoneum sits outer from it. We get a space in between those two membranes. That is going to be our peritoneal cavity. Just like the other two, we had a lubricating function. As we undergo peristalsis and segmentation and moving foodstuffs through that digestive tract, we have the potential for friction. The peritoneal cavity reduces that friction. But also like the other two cavities, we see a very specific function for the peritoneal cavity that helps digestive function. We get the peritoneal cavity make up what we call the omentums. The omentums are going to be bands of these membranes that merge together and anchor the various digestive organs onto their respective places in that abdominal cavity. It prevents any of the more superior organs from being pulled by gravity and putting compression on the lower intestines, therefore making it more difficult to move foodstuffs through those organs. So here we see our visceral layer, our parietal layer, the peritoneums, making up the peritoneal cavity. And then we get these bands of membrane adhering those digestive organs to the abdominal wall. These are going to be called the omentums, or the mesentery, depending on which specific organ they happen to be attached to. I want to thank you again. Hope you enjoy.